Meeting of the City Club of Portland. I'm Jim Westwood, your president. As always, we introduce our new members, and several of them are here today. I'll name all of our new members because thanks to our 75th anniversary and also the great things we do where membership is picking up like a railroad train. We have several new members. I'll announce several of them are seated in the audience today, and I'd ask them to stand and please hold your applause till I've introduced everyone I've named. First, Julie Goodrich, Advertising and Sales Representative for KLYC Radio. Nancy Gorshi, or Gorsh, I'm sorry I don't have that pronunciation right, Executive Director, Providence Elder Place. Joseph Lieben, Assistant Dental Director, Permanente Dental Associates. Sherry Roden, owner of Roden Communications. Christian Steinbrecher, Chief, Construction and Engineering Management for the Portland Development Commission. And Paul Sachiwa, Associate, Hallmark Keating and Abbott PC. Welcome all of you to City Club. We're very glad to have you. And my thanks to City Club member recruiters of these new members, Cynthia Cato, Grace Kroniken, William Gilliand, Brian Kelly, and Ethelyn Pankratz. Next Thursday, October 31st, a science breakfast entitled Technology Literacy, Guidelines for the 21st Century. It features Henry Petrosky, a PhD and professor of civil engineering at Duke University. This is sponsored by the City Club's Science and High-Tech Standing Committee and also jointly by the Institute for Science, Engineering, and Public Policy at Portland State University. This will be at the Heathman Hotel next Thursday, October 31st, and it's a science breakfast, so it's at 7:30 in the morning. See this week's City Club Bulletin for details. Next Friday, a week from today, November 1st, back here at the Benson Hotel in the Mayfair Room, Ramona Edelin, President and Chief Executive Officer of the National Urban Coalition, speaking on the competitive edge, preparing youth for the 21st century. This is timely and important to City Club as well. She'll discuss the National Urban Coalition's pioneering Say Yes program, an early intervention family learning program that exposes African American, Latino, Native American, and female children to mathematics, science, and computer technology. Again, this will be in the Mayfair Room. The program next week will be co-sponsored by the Black United Fund. One further announcement I'd like to make, usurping the prerogative of the chair to its limits. As a loyal alumnus of Portland State University, I'd like to announce that the public is invited to a special weekend at Portland State on November 1st through 3rd. Let knowledge serve the city is the theme. There are 7 different events that include over 30 lectures, all of them open to the public, not just to Portland State alumni. And there are brochures on the table by the door. You can pick those up on those tables. Today we have, as part of our program, one of the special events that City Club has justly and long been known for, presentation of the results of one of our long-term research studies. Depending on the length of the debate of the report, today's program may run over time and we may go as late as 1:30. As you know, all City Club reports are written by our volunteer members who are carefully screened for conflict of interest before they're appointed to serve on a research committee. City Club committees research very carefully all the available information. They interview experts on all sides of any issue they examine. This study of racial and ethnic relations consists of 6 separate subcommittee reports. Last month, the club officially adopted the subcommittee report on citizen participation and social associations. Today, we vote on the second subcommittee report, and you who are present represent the entire City Club membership, and you'll have the opportunity to discuss, debate, and vote on the final report and its recommendations. Today we're voting on the report of the Health and Welfare Report Subcommittee of the Study of Racial and Ethnic Relations in Portland. This was 2 years in the making, and the publication of this report and its recommendations follows a lengthy review by the City Club Research Board and Board of Governors. This report has not been without its controversy. I'm sure you saw on the table as you came in a response to the City Club report by the Oregon Department of Human Resources. We are glad to have this dialogue opened, and we certainly welcome all commentary from all City Club members as we debate this motion. You've received copies of the City Club report printed in this week's bulletin. The Health and Welfare Subcommittee report will be presented by Helen Lee, Subcommittee Chair. This report does not contain a minority report, and upon completion of Ms. Lee's presentation, she'll move for approval of the report recommendations, and the meeting will then be open for debate and comment from City Club members. I emphasize that, City Club members in the audience. Please be reminded, it is club policy that only City Club members may speak. I also request, since this is likely to be a lively debate, that you keep your discussions to the point and as brief as you possibly can. Before I introduce our presenter, I want to review the club's bylaws briefly on report votes, and you find copies of the bylaws on your tables. The following motions are allowed. 1, to accept or reject individual report recommendations. 2nd, to postpone consideration of the entire report or further consideration to a subsequent meeting, and that's a debatable motion requiring 2/3 majority for adoption. A third possibility is to postpone consideration of the report indefinitely. That also requires a 2/3 majority vote. A motion to table and a motion which would otherwise delay consideration of the main motion beyond those I've already announced would be out of order. Fortunately for me, Charles Hinkle, a partner with the law firm of Stoll, Reeves, Boley, Jones & Gray, and a former City Club president, will serve as the parliamentarian for the debate today to keep me out of trouble and to keep everybody honest. Now I would like to introduce Helen Lee, who has served as chair of this study throughout its research process. Helen is an assistant vice president with First Interstate Bank, has served on several other research study committees, as well as on the City Club Research Board, and currently she's a member of the Board of Governors and serves as the club's treasurer. Helen, you've been very, very busy for the last few years. You've been an active member of City Club for 17 years, and I now turn the microphone over to you for presentation of the report. Helen Lee.
Thank you. This committee's report is the work of a dedicated and knowledgeable group of City Club volunteers who have worked diligently in the City Club tradition to examine the information available on this topic and present it and their recommendations to you. I would like to thank them and introduce them to you. Present in the audience are two members, Peggy Bird and Carolyn Prendergast. We also included Letizia Maldonado, Dar Sawyer, and Norm Wires. I would also like to thank our final research advisor, Jim Larpenter, whose skillful and tactful guidance was such a help during the writing and presentation phase of this report. I think it is appropriate to take a minute to review for you the process of research in this report. In addition to forums conducted for the combined study committees featuring experts in the fields of human and racial relations, this committee's research included interviews with some 30 individuals, officials of state agencies, academics, and representatives of neighborhood and minority groups. We also convened 2 panel discussions, one with welfare workers and one with welfare recipients. In all, about 50 people gave us the benefit of their knowledge, views, and experience. We also studied a large array of statistical data, most of it provided by the agencies of the Oregon Department of Human Resources. In keeping with City Club policy, the draft of the background and discussion section was submitted for correction and comment to the provider of the data, in this case to the Director of the Department of Human Resources, the Administrator of the Adult and Family Services Division, and the Manager of the Health Services Section. Their comments were given very careful consideration in the final draft of this report. In presenting the subcommittee's report today, I would like to emphasize 3 themes. First, the problems in society at large of racial stereotyping. Second, barriers to service in welfare. And third, the disparity in dollars spent on Medicaid recipients. First, stereotypes. The poverty issues of welfare and healthcare services are often seen by the general community as being especially applicable to the concerns of racial and ethnic minority persons. Our committee is at pains in the report to point out to you and the community as a whole that this is a pervasive and inaccurate stereotype. It is certainly true that minority persons suffer disproportionately from poverty, but not all or even most minority persons are poor. Furthermore, not all or even most of the persons receiving public aid are minorities. In our report, we discuss both the evidence and the perceptions of racial and ethnic bias. In society at large, a further bias exists, a prejudice against poor people. In this context, there is the theory of the underclass, which is seen as chronically poor, welfare dependent, and living outside the typical American societal values of self-reliance and community responsibility. Unfortunately, the concept of the underclass plays into some people's prejudicial stereotypes. leading to such myths as most welfare clients are minorities, in fact, most welfare clients are white, or that people return to welfare, the revolving door syndrome, because they don't like to work. We were told that many people return to welfare because they can't get health care coverage for their children at their entry-level jobs. In whatever way it is labeled, adding class bias or prejudice against the poor to racial bias exacerbates the problems of the minority poor. Second, welfare. The study deals with income maintenance and health care services. To obtain a manageable scope for this report, we have concentrated on the largest programs: welfare assistance provided to families of needy children under Aid to Families with Dependent Children, or AFDC, and health care provided to the poor through Medicaid. Minority participation in welfare programs is roughly proportionate to minority poverty. Our charge was to examine the administration of these programs for fair and equitable treatment of minority clients. In all of our interviews with providers and recipients, as well as spokespersons for minority organizations, we found no evidence or allegation of institutional bias against racial or ethnic minorities. The letter and the spirit of the law are followed by the state's Department of Human Resources agencies. However, there were anecdotal references to biased behavior on the part of individual welfare workers. Furthermore, there was a substantial body of testimony having to do with cultural insensitivity and language barriers to access to services. The committee recommends that the Department of Human Resources and the Adult and Family Services Division deal with these problems through expanded mandatory training in cultural sensitivity and through the inclusion of cultural competency in job performance evaluations. Also, we encourage AFS to more vigorously pursue its goals of minority hiring and promotion, particularly at the branch manager level. In spite of repeated requests for information about complaints of racial or ethnic bias, we could obtain no information regarding the extent, nature, or resolution of complaints. We recommend that the Department of Human Resources document complaints and make this information available to the general public. It should be pointed out that welfare recipients fear retaliation and say they seldom complain. Administrators of the agencies deny that retaliation occurs. Third, Medicaid. In health care, most Medicaid services are provided by mainstream hospitals and medical facilities. Because language and cultural barriers to access can be so critical to minorities in obtaining health care, we also examined several community-based health care agencies. These agencies provide positive models for the community in cultural competence and language proficiency in the provision of health care services. There is a body of research cited in our study which supports the conclusion that the general state of health and health care are deficient for several minority groups. Insufficient prenatal care, high infant mortality, and higher age-adjusted death rates among minority groups point to inadequate health care for many minority persons. Furthermore, there is a striking disparity in the utilization of Medicaid services between white and minority patients, as measured by average dollars per recipient. The average per recipient Medicaid payments for white clients in 1989 was nearly twice the average payment for minority patients. The disparity continues among the elderly. The average per recipient expenditures for minority persons over 65 was between 36% and 71% of that for white recipients. The fact that Oregon's experience mirrors the nation as a whole in no way explains this appearance of unequal treatment. The committee recommends that the State Department of Human Resources investigate the disparity in money spent on health care for different racial and ethnic groups, report its findings to the legislature and the public, and take remedial action as appropriate. In conclusion, this committee wishes to comment that Portland's population is becoming ever more diverse, and that public agencies, to effectively and fairly serve their clients, must continue to expand their knowledge and competence in dealing with a culturally and linguistically diverse client base. Mr. President, on behalf of the committee, I move adoption of this report. Thank you.
Thank you, Helen. Is there a second to the motion? I hear a second. We're now ready to debate the motion to approve the report. The microphone to my far right, that is to your left, is labeled in favor. Actually, it says for, I think. And the one to my far left is labeled against, opposed, negative, whatever you'd care to say to that. I will try to alternate between the two positions, and will first recognize someone favoring the report. Remember, City Club members only may debate the report. Please limit your comments to 2 minutes, and remember, you don't have to take 2 minutes, so that everyone will have a chance to speak, everyone who wants to. Our timekeeper, and we will have a timekeeper, is Jackie Harper, who is seated here in front of me. Members are also encouraged to ask questions, and you can go to either microphone to ask a question, and Helen or members of her committee will be glad to try to answer those questions. The committee, speaking of the committee, I should mention the members of this committee who deserve credit for having done a long and arduous job. In addition to Helen Lee, the chair, Peggy Bird, Letitia Maldonado, Carolyn Pendergast, Dar Sawyer, and Norman Wires. Our thanks to all the members who served on that committee. So I'm ready to recognize anyone who'd care to speak in favor of adoption of the report. I see no one at that microphone. Do we have anyone with a question or ready to speak in opposition? See someone moving apparently to the microphone in favor. Is that correct? Or a question? Identify yourself, please, and we'll take it from there.
There's not a middle microphone.
Constructively, you're right in the middle of it, Charlie.
My name is Charlie Davis. I will move to postpone the consideration of the report by this body, and if I get a second, I will explain why.
Second. I've heard a second. Go ahead.
All of the recommendations made by the club are to others. The first 4 are to the Department of Human Resources or Adult and Family Services. The 5th is to other providers in the community. We have received today a response from the Department of Human Resources which raises questions about the accuracy of the report. And it seems to me, since that's the organization that will have the lion's share of implementing any suggestions we've made to them, that we ought to hear them out. And in reading the recommendations, I see nothing here that has a timeline to it that would put the report in jeopardy at the end of 30 days. And now my understanding is if the board or the committee want to revise the report and bring it back to us, or bring it back to us as it is, they can do that. But I would argue that we ought to have an opportunity for the board and the committee to review the comments made by the Department of Human Resources.
Could I clarify your motion? Is it a motion to postpone indefinitely or a motion to postpone to a particular date?
Well, as I read the bylaws, that's the issue that will be decided by the Board of Governors. They can bring it back whenever they want to. A motion to postpone is a motion to postpone.
Well, you would be proper to move to postpone and have it reconsidered or considered again at a given date, but I understand you'd like to postpone indefinitely then. Is that correct?
I'm postponing
understand.
it under the bylaws. Okay?
That it would be postponed with the understanding it does come back to the club.
That's correct. Mm-hmm.
I understand.
Okay.
Mr. Parliamentarian, this is a debatable motion, is that correct?
Yes, it's a proper motion.
It's a proper motion, it's debatable, but only as to the propriety of the postponement. Please, not to the merits of the report, to the extent you're able to just confine your comments to that. We've had a speaker in favor of the motion to postpone. Is there a speaker against the motion to postpone? I see one coming to the microphone.
Chuck Williams, member. I will speak against postponement. I think we should carry forward this report right now. I do have some reservations about the report, even the content of the material, but I think the recommendations are fairly straightforward and probably benign enough that we should act now. I think the research board went through this, the Board of Governors went through this. I think the time to act on this is now. I did go through and detail the rebuttal, I should say, from Human Services. I think there are many things that we could pick at in this report in terms of the content of it but I don't think it would change the recommendations. So I would urge that we move and vote on this report today.
Speaker in favor of postponement?
Ray Polani, a City Club member, I would propose that postponement would be in order, and I would suggest that during the period of postponement that the committee explore the role of the Oregon Department of Transportation, which should provide public transportation options for all, but particularly for the underprivileged and the poor.
Thank you. Is there a speaker against postponement? Yes.
Anna McManus, Chair, Human Services Standing Committee. I am against postponing adoption of this report. I believe that the committee provided an opportunity for the department to work with the committee and provide data. And at this point, we have a report, and I respect the work that the committee has done. The department always, in an ongoing timeline, has an opportunity to go further with the public and public information, but I believe it's a well-considered report and that we need to move forward with it at this time.
We'll hear from a speaker in favor of postponement.
Yes, my name is Jean Pullen. I'm a member of the City Club. I'm also a manager of Adult and Family Services West Portland. I very strongly would urge to consider postponement. I find that there are a number of inaccuracies in it which may seem small to somebody outside the agency. I would say that within the agency, within line staff, within staff who have felt that they've really been tried to be more than sensitive to the needs of agencies, to the minority population, to all of our populations, feel insulted and again under attack by it at a time when we're facing a lot of other attack. On a more personal note, I can say that I have managed a branch for the last 12 years that has serviced a very large minority population of ethnic minorities, of the Asians. I've had many staff members. I would certainly question the conclusions drawn in the Medicaid portion that somehow the ethnic minorities are being deliberately discriminated against by Medicaid on the basis of the payments. I think if we had taken a breakdown and looked closer at the number of the in-home services that were being paid for under Medicaid, you would find that a large population of the Asians choose to stay at home, and their families choose to keep them at home. I've done this even when we had problems when they should have gone to a nursing home, and they said, if I go to a nursing home, I will die. And when they did have to go, they did die. And a lot of that we felt was because of their cultural belief that the family was abandoning them. Thank you.
Is there a speaker against postponement?
Ted Falk, City Club member. I think that the response by Mr. Concannon raises a number of interesting issues about City Club process which are worthy of consideration by the board, but I don't think they need to delay action on this measure. All City Club research reports are the product of committees of dedicated amateurs, and we can't expect amateurs to grasp every little detail of one of the state's largest and most complicated bureaucracies, one which even people like myself who work day in and day out in healthcare have trouble understanding. I would point out that my understanding of the effect of a City Club adoption of a report is endorsing the recommendations in the report, and together with the general support for the preceding document as giving support to the recommendations. It is not an endorsement, as I understand it, of every statement in the report. The recommendations that are made as to the Department of Human Resources, as I understand it, Mr. Concannon's position is that recommendations 1 through 3 have already been complied with, and that recommendation 4 is so innocuous, I find it hard to understand how anybody could complain about it. It simply calls for a study of an issue. So I would suggest that the report should be acted on today.
Speaker in favor of the postponement.
Thank you. I'm Bob Shoemaker, member of the club. I would argue that we should postpone. There's one particular part of the report that's particularly troubling to me, and I think will be troubling to others outside these halls, perhaps back in Washington, where the appearance of things is often weighs more than the reality. I think the recommendations of the report are not out of line. But what I'm particularly troubled about is the conclusion number 7, which says that the appearance of racial and ethnic discrimination in the provision of Medicaid services is overwhelming. Now, discrimination is a pejorative term. It carries with it intentional discrimination. I think the facts show that there is a disparity, certainly, but I don't think the facts show that there is overt discrimination against ethnic minorities. And my concern is that if this club adopts this report, including that conclusion that there is discrimination against minorities, for one thing, I think it is an unfair slap at Office of Medical Assistance Programs, but I also think it can have repercussions far beyond the City Club, which can be very damaging to the Oregon Health Plan, which all of us, many of us, have worked so hard for over these past years. So I really urge that we refer it back to committee and let them at least think through that conclusion again in light of all the evidence that they now have. Thank you.
Thank you. With that, I think, final argument in favor, let's proceed to a vote on this motion without objection. You have been issued voting cards. They're these little squares. And I should remind you that a motion to postpone requires a 2/3 affirmative vote to pass. I'll give an eyeball shot from the chair here, but if anyone is in doubt and wishes to ask for a count, you're certainly welcome to have one after we've voted. So we'll now proceed to vote. All those in favor of the motion to postpone and refer this report back to the Board of Governors with the understanding it will come back to the club at some future date, please raise your cards. With those opposed, please raise your cards. Of course, it looks very close. I would like to have a count. So would you please raise your cards again if you're in favor of the motion to postpone? We have tellers, and they'll give me a sign when we're done. I don't see too many bare hands out there. I just want to remind everyone, City Club members only, of course, are entitled to vote with your voting cards on this. Do we have a total yet? We do. All right. Please lower your cards. Those opposed to the motion to postpone, please raise your cards. Sorry for the necessity of taking this count, but it looks like just very close to me. Does anyone have a calculator in the house? Do we have a count? While you're doing the calculations, I suppose I could ask if anyone has a question about the report, since we're not. Do we have a count on the against tellers? Do we? I think yes. I think everybody who was against has been counted now. We'll get the result here soon. But if anyone has any questions about the report, we'd certainly be willing to entertain those at this time. Yes, I see someone with a question.
Would a comment be appropriate at this time?
I think so.
I've been confused as a new member about which way to go, but being in the business of healthcare for 20 years in long-term care.
Could you identify yourself, please?
Nancy Gorshey, new member. I was concerned about the Medicaid side in that I noticed in the interviewing list that there were no interviews with people who are the experts in the aging side of Medicaid on the community-based side, senior disabled services, advocates at universities. There are some reports that have been out on minority usage, utilization of services, both community-based and long-term care services that I think would have helped enrich the issue. And also dealt with a difference in longevity. I think longevity was slightly treated in this report, and I think that makes a very big difference in my experience in long-term care. And then finally, just a comment about there's a real strong bias in the report that skilled nursing care, long-term care is a better, more valued service. It's certainly more costly than community-based care. And I think in the studies of serving minorities, we find that they have a problem with needs for more help in activities of daily living, which are only paid for under community-based service systems, not under traditional Medicaid and Medicare. I just think those are concerns that could use addressing.
Thank you. Let me construe that as a question to the committee. Did you consider the matters that have been raised. Any member of the committee? Helen Lee, would you like to comment briefly on that? And then we'll have the count. You can go to the microphone on the floor if you'd like.
I think it's important to say that what we conclude is we're unable to explain these differences, and we are asking for an explanation. I think it's important to point out that the department in its statement says they're not responsible for Medicaid usage. They issue the cards, and it's up to the clients and their physicians or medical advisors to choose what services are to be performed. And to say that we did not say that the department is responsible for this disparity, we did think that they were the appropriate people to enlighten us all as citizens about what causes this. Part of the draft report that we submitted to the department included the phrase, "We are unable to account for these disparities." The comments we had from the department were that it was probably a matter of age. And so I hope that answers some of what we were trying to do. We were trying to get at these issues.
Thank you, Helen. The result of the vote: in favor of postponement 61, opposed to postponement 35. By a 2-vote margin, pardon me, the motion fails to get the 2/3 necessary. So we will proceed now to discussion of the main motion, which is to adopt the report. I think we've had some good discussion already that touched on the merits of this. Please remember, keep your comments as short as you possibly can, because we are running short on time, but I certainly encourage everyone who'd like to speak either for or against this report. Do we have a speaker in favor of the report at this time? Yes, I see one.
Peggy Bird, City Club member and member of the committee bringing you this report today. I would urge adoption of this committee report. You can see from the list of people that we talked to, we had significant input from various departments within the Department of Human Resources. As Helen has already pointed out, they reviewed the discussion section. We have given weight to their considerations. These are our conclusions and recommendations. We are delighted that they believe that they have made some progress on the things that we have recommended. But we believe that those recommendations are still valid and that they need to continue the process that they have done of improving the programs that they have in place. I think that if you read the report carefully, we are making no allegations of institutional racial bias. What we are suggesting is that we have a set of numbers, both from Oregon and from the nation, that says we spend more money on different ethnic groups. We'd like to know why. They're very curious figures. It's curious to us that they have nationally known those figures for almost 20 years, and we'd like to see some explanation of that. It is not any allegation of racism in the institution. I would urge adoption of the report.
Is there a speaker opposed to the report? Yes.
B.J. Seymour, City Club member. I'd like to underscore what a couple of the previous speakers have said, namely that longevity makes a difference. If you go into a nursing home and you stay there for 5 to 10 years, as many white recipients do, I've been a social service consultant in nursing homes, and I'm aware of that. That makes a big difference as compared with someone who goes into the nursing home and lives only a short time thereafter. There is a difference in the number of or percentage of recipients over 85 years old, which is the typical nursing home age, who are white versus a much smaller number who are members of minority groups, and that does skew the figures. In addition, I think there are differences in receptivity on the part of the medical community to some people who don't speak English clearly or are members of minority groups, and that makes a difference in utilization of medical care. So I think these factors need to be looked at and have not been looked at adequately in the report, and therefore I recommend against the report.
Thank you. Is there a speaker in favor of the report? Yes.
Mr. President, if you will indulge me now speaking for this motion. There are a couple of things here. This is not a comprehensive analysis of all aspects of healthcare, racism, and so on. As a lay reader, reading the report, I felt that there was never an implication of an intent to discriminate. I think item 7 says very clearly there's an appearance of discrimination. And indeed, from the numbers that were being provided, I can understand the committee's conclusion. As someone who has been poor, as someone who has used healthcare facilities and state services as a young person, I read it made a lot of sense to me, the things the committee was saying. I thought they spoke to these questions, some of these challenges, very eloquently, and I don't think the report makes anyone out to be a bad guy. But these are questions, and they're questions that the department, healthcare providers, and users of healthcare services of this kind can benefit from all of us discussing these questions and looking at these statistical results. And if they're in error, that's fine. Let's move on and find out where they're in error. But I think the committee has a very reasonable report here, given the scope of the work. And I do not feel that they are saying that there's an intent to discriminate. They're saying that there's an appearance, and that seems a fair statement to me.
Thank you. A speaker against the motion to accept.
Mary McCarthy, member. I agree with what Bob Shoemaker said about conclusion number 7. I think to say the appearance of racial and ethnic discrimination in provision of Medicaid services is overwhelming and cannot be denied is almost contradictory. To say there's an appearance and then to use such drastic language as overwhelming and cannot be denied are saying the opposite. I think that particular sentence should be eliminated from the report or rewritten in a less accusatory way. Because I do agree that Medicaid, it's the employees who operate the program have been under a lot of attack, and that there's a lot of serious harm that comes out of those kinds of attack to the people who work in those offices. They have very difficult jobs. They're working under limited resources, and sometimes the patients will suffer if there's more attack on those kinds of agencies. I think that particular part of the report needs to be eliminated, so therefore I'm voting against it.
Is there a speaker in favor? I see none, so we'll hear one more against.
A question.
A question, yes.
Which may make a lot of difference given the comments I've just heard. Mark Anderson, member. Is a vote in favor of this report a vote in favor of it in toto, the conclusions and recommendations, or just the recommendations?
Fortunately, our parliamentarian is a former City Club president who may be able to help me out. Is there a history on that, Charlie Hinkle?
Recommendations.
The recommendations only are being voted on. Thank you. Let's proceed to a vote unless I see one more person. Would you?
I want to affirm the parliamentarian's observation, but I want to observe also that City Club reports in terms of conclusions and facts and presentations are generally used in the legislature and elsewhere to support positions that folks are taking, so that if this report has inaccuracies in it, the time to correct it is now.
Thank you. Is there one final speaker in favor, or anyone? That's the prerogative of the affirmative on a motion, but I see none. Let's proceed to a vote. The question is approval, adoption of the recommendations and the report that's before you. It requires a simple majority. Please use your voting cards. Would those in favor of the adoption of the report's recommendations please raise your cards? I hope it's not going to be that close again. Would those opposed please raise your cards? Oh dear. I believe the motion has passed. Is there a request for a count? Would you like to see the votes one more time so anyone who is in doubt can ask for a count? Would those in favor please raise your cards? And those opposed, please raise them high so we can see. Yes, I believe there is a clear majority. I declare that the motion has passed, and thank you again to the committee. Let's move quickly into the speaker for today. I can't say I regret that we took this long, but we have a very important speaker today. Our board host is Mary McWilliams, seated at the head table. She'll ask the first question. Second question will be asked by Ramona Johnson, member of the Human Services Standing Committee of the City Club, and of course after that we'll open up the meeting as time permits to questions from the floor. Congressman Ron Wyden has represented Oregon's 3rd District in Congress since 1980 when he burst on the scene with an upset primary victory over Robert Duncan, the incumbent. Born in Wichita and graduated from Stanford University, Congressman Wyden came to Oregon to attend law school in Eugene and has stayed. He received his law degree from the University of Oregon in 1974. His credentials as a healthcare specialist date from the 1970s when he co-directed the Oregon Gray Panthers, directed Oregon Legal Services for the Elderly, and was an instructor of gerontology at Portland State, the University of Oregon, and the University of Portland. In his 6 terms in Congress, Congressman Wyden has earned a reputation as a leader in federal health policy issues, as a champion of women's rights, and as a hard worker who stays active and keeps in touch with his district through frequent trips back home. That may explain why the Oregonian reported earlier this week that the only 2 congressional perquisites he takes advantage of are the Capitol Health Club and free parking at National Airport, so he can get back to Portland. It is timely and appropriate, though, that as Congress is considering decisions that have potentially far-reaching effects on health care in Oregon, and as women's issues are coming to the fore as never before, that we welcome today's Portland City Club guest, Congressman Ron Wyden, to discuss the politics of health care for women. Congressman Wyden.
Well, Jim, thank you very much. And let me first say, watching this orderly debate that you all have just had on the Medicaid report, I think we ought to transport your rules and decorum for conducting these debates to the Congress, because you have done it in a much more civil and rational way than we do. And let me just say about the report, I have not read it, but I think it raises very troubling issues that just cry out for further explanation. And I heard mention in the audience of the fact that federal dollars are involved in these programs as well. And I am going to follow up, as the City Club has now voted to do, to get further information on this, because these are not issues that should simply be left there to gather dust, but ought to get further explanations. I commend you for your efforts. This is, of course, extraordinary times to be in public service. Jim made mention of the fact everyone wants to talk about perks and that kind of thing. My colleagues are coming back from their districts now with incredible stories about what their constituents are saying. But my favorite of late is that one of my colleagues took a group of students onto the Capitol steps very recently. He asked them if they had any questions. They too wanted to know about his bank account number and all of this kind of thing, but he couldn't get them to really ask about any kind of policy questions. So after a couple of minutes, he said to the kids, well, do you kids see any difference between your class there in school and the United States Congress? And one of the kids quickly threw up his hand, says, yes, Mr. Congressman, I do. We always have adult supervision. So we are taking a pummeling in the Congress, and I had been particularly looking forward to coming to City Club today, because I think that in the last few weeks, millions of Americans have been galvanized to the debate over some of the most important social issues in our country. And in particular, we're very startled to learn through the televised debates that many women in this country had been sexually harassed in the workplace. Across the country, in coffee shops, in churches, on the sidelines at Pop Warner football games, and of course in the Senate caucus room, this country is now debating the issue of sexual harassment. Quite clearly, many men couldn't identify with the problem. They didn't understand it, and they didn't understand it because they had never experienced it. They had never had a job or a promotion threatened as a result of sexual harassment. They had never suffered the degradation and frustration, and it was quite clear that there was a very big gulf between millions of men and women on this issue. I come today to say that the gulf that separates men and women on the issue of sexual harassment is not the only barrier that is holding back progress in our society. A similar divide now exists on the critical issue of health care for 127 million Americans, 127 million women in this country. And I want to be very specific. The 1980s were the dark ages of health care for women in this country. Research on catastrophic illnesses afflicting women, the development of new life-saving drugs, family planning, and reproductive rights all were victimized by a hostile takeover. Two presidents, Ronald Reagan and George Bush, spent a decade pandering to the political right, and by impeding scientific progress, untold numbers of women have died and suffered as a result of their political malpractice. Ronald Reagan sat on his hands in the face of clear discrimination against women in medical research trials, and he opposed significant additional funding to attack breast cancer. George Bush said doctors shouldn't have to be straight. They shouldn't have to be truthful with their patients in federally funded family planning clinics. Because of the often close relationship of abortion to contraceptive-related research, political taboos in both the Reagan and the Bush administration, reproductive research across the board has been stymied and in some cases halted altogether. This bias has also stalled development and production of new drugs that would have a variety of therapeutic values both as it relates to non-abortion health care services and abortion. Clearly, these malignant political judgments have denied many women access to health care in this country and have denied many women access to basic political and health care choices. If the tables were turned, I would ask, how many of the men, if they were targets of these health practices, would have been willing to accept this misplaced set of priorities? Now, the individual who's best positioned in this country to turn this national disgrace around is George Bush. But in the last few months, the president has talked mostly about the health care for women that he's against. The president is against, for example, and has promised to veto legislation that would reauthorize the National Institutes of Health because Congress wants to permit federal labs to conduct life-saving research with fetal tissue. The president is on record as being against fair treatment of RU-486, the French abortifacient drug, which shows great promise in fighting a wide variety of diseases, including breast and brain cancer, Cushing's syndrome, endometriosis, and a wide variety of health conditions. And what's particularly amazing is the president wants to inflict these priorities on Americans and non-Americans worldwide. The president is now threatening to veto the Department of Defense authorization bill because that bill would permit servicewomen overseas to pay for their own abortions at U.S. military hospitals. And the president is also wielding the veto pen on the foreign aid reauthorization, which would allow international family planning groups to receive U.S. aid, and get this, even if they used private money to give counseling as it relates to abortion. Beyond making the politically correct responses to his supporters on the far right, the president has no real agenda as it relates to health care for women. Now, rumor has it that there is a presidential campaign coming up. I don't know if this is for sure, but I hear kind of rumors about it off and on. In the hope that all of the candidates, Republican and Democratic alike, will be forced to address the important issue of women's health, I like to spend my remaining time trying to light just a few lampposts to help speed them along the road. In the area of medical research, there is an enormous body of evidence that women have been systematically excluded from projects sponsored by the National Institutes of Health, and that the agency has not made adequate efforts to include women in clinical trials. According to the Bipartisan Congressional Caucus on Women's Issues, the National Institutes of Health spends only 13% of its budget on women's health care. This is in spite of the fact that the death rate from breast cancer increased 24% between 1979 and 1986, and 1 in 9 women can now expect to develop breast cancer in their lifetime. Women are the fastest growing group of those who are infected with AIDS and now make up 11% of all reported AIDS cases, but still they have gotten short shrift in research funding. And women are twice as likely as men to suffer from depression. 1 woman in 4 will suffer a serious clinical depression at some point in her life. As just one example, cardiovascular illness is the #1 cause of death and disability in American women. But when a massive research project on heart ailments was developed, the multiple risk factor intervention trials, there were 15,000 men involved in this and not one single woman, not one. Now, the New England Journal of Medicine says that this may be a matter of gender bias within a male-dominated medical establishment. Now, you obviously can't hang that one on the White House or any particular political party, but I would submit to you that the president can and should use that office as a bully pulpit, as a forum to organize against these particular health problems. The president ought to be the one who sets the tone and the direction to tackle these kinds of health concerns. And unfortunately, the White House is missing when it comes to that particular call. The result has been that in the area of contraceptive research, technologies, and choice, many women in the third world today have access to more services and more contraceptive choices than do women in this country. According to Dr. Carl Gerasi, the chemist who developed the pill, we hold the dubious distinction of standing only with Iran as the only country where contraceptive research actually regressed in the 1980s. Even more important, the lack of contraceptive research and choices has now made responsible the prospect that sterilization will often be the birth control method of choice. The National Center for Health Statistics has indicated that 39.1% of American women have chosen sterilization, while the pill is the choice of just 30%. Amazingly, both the National Institutes of Health and the pharmaceutical industry find themselves hogtied with respect to new drug trials in general by regulations from the Food and Drug Administration which prevent the use of women subjects in clinical trials. The result, we really don't know the effect of many of these drugs on women compared to men. The exclusion of women in phase 1 trials, particularly important trials, assess the safety and dose of experimental drugs. They put women at risk if side effects in women are not studied at this level. It's particularly important to assess the dosage level, and women have not gotten a fair shake in these trials as well, which has been documented most recently in February of this year. There are just 2 other subjects that I wanted to touch on, and then would be happy to take questions from you. The political bludgeoning of RU 486 is especially unfortunate because it is a political bias that is thwarting research and commercial use of a new drug with widespread potential value to women. It's manufactured by the French firm Roussel Clef. It is currently the object of an import alert enforced by the Food and Drug Administration even though there is absolutely no evidence that anyone has tried to illegally import it into the United States. There's just one reason for the administration's concern, and that is they're trying to send a message to the far right that they won't give this drug, a drug with widespread potential benefits, a fair shake if someone submits it to the FDA for approval. Over 58,000 American women die each year from breast and brain cancer. That's more Americans that died in the entire Vietnam War. RU-486 has the potential to help them. But our administration, instead of saying that this drug would get a fair shake at the FDA, that this drug would be evaluated like any other drug, by the book, in accordance with the rules that are laid out by the FDA, our administration has said no. We're going to take steps to block it, to keep it from getting a fair evaluation in this country, and it is a shameful action given the problems that women face in this country in terms of breast and brain cancer and the need for alternatives in contraception as well. Finally, I'd like to mention the question of the gag rule, the rule that the Bush administration has pushed hard for before the Supreme Court and goes right to the heart of health care in our country. Traditionally, health care has been built around the idea that the provider, doctors, and others are the advocate for the patient, and they arm that patient with all the information that's needed to make intelligent, informed choices about their health care. The gag rule, in effect, turns that notion about medicine on its head. The gag rule says that if a woman is sitting across from a doctor in a federally funded family planning clinic, that doctor can't tell her the truth. That doctor can't be straight with her. That doctor can't tell her what all her health care options are. It is an extraordinary decision, a decision with implications way beyond the question of abortion and family planning, because many First Amendment lawyers feel that it sets in place the principle that if the government pays for a program, the government can control the quality of speech that's taking place there. So it is an extraordinarily important decision, a decision with enormous impact on women's health care and enormous impact as it relates to the government funding of services generally. As it relates to health care, to bring it down to some specific examples, under the gag rule, pregnant women with diabetes or with genetic risks of Tay-Sachs disease or sickle cell anemia couldn't be informed of the results of their pregnancy on themselves or their fetus. A woman with pulmonary hypertension, a condition that has a 50% morbidity rate for pregnant women, couldn't be told of their life-saving options. Now, I'm not making this up. This is direct, actual information supplied by Dr. William Archer, who administers the program. On the first day of this Congress, John Porter, a Republican from Illinois, and I introduced legislation to overturn this gag rule. We now have about 170 supporters on this legislation. We are going to pull out all the stops to build a 2/3 base of support in the Congress so that we could override a presidential veto. I'm hopeful that all of you and others will communicate your concern about this issue because it has enormous impact, potential impact on government services generally, immediate impact on the health care of women in this country, and as far as I'm concerned, would do enormous damage to the role of health care providers in our society as the advocate for their patients. Let me conclude by saying that I'm very hopeful that the upcoming presidential campaign will force both political parties and all candidates running to address these very serious inequities. Until then, an activist Congress, members on both sides of the aisle, is going to have to take the lead if we're going to see reasonable improvements in women's health care. It would be wrong to let one more year pass without fighting for progress on women's health issues, and there are a number of steps that can be taken right now. The House has approved legislation authorizing additional funds for health research, $50 million additional for ovarian cancer, $40 million to tackle the problem of osteoporosis, $50 million for additional research on breast cancer. But the administration has sent a letter to the chairman of the authorizing committees specifically opposing every single one of these research initiatives. What's the message? You've got a better chance of getting U.S. funding if you're a struggling collective factory in the Soviet Union than you do if you're somebody who wants to research health problems for women in this country. That's wrong, and it's got to be changed. I also hope that in this session of Congress, we'll be able to move forward with our legislation to overturn the import ban on RU 486. The chairman of the committee with jurisdiction over the legislation has joined as a sponsor of it, and I'm very hopeful we'll be able to make progress on that bill as well. Finally, I hope that the gag rule is buried and interred for all time. This is one of the most blatant and unredeemable assaults on our nation's healthcare system in years, and we're going to have a floor vote on the Porter-Wyden legislation sometime within the next few weeks, and I'm very hopeful that we'll have the two-thirds basis support we need to override presidential veto. Over the last few years, the City Club has consistently been out in front of the fight for justice and fairness. And I come today to ask all of you to join the fight for a new bipartisan approach to improving women's health care that's built on good scientific judgment and not political expediency. Thank you very much.
Thank you, Congressman Wyden. We do have time for questions as time permits between now and 1:30. And our first questioner is Mary McWilliams, the board host.
Ron, I'd like to ask you about another issue about health care of interest to Oregonians. And I know you've been a great supporter of the efforts to reform Oregon's Medicaid plan. Critics of those plans say that it discriminates against women and children, poor women and children. And I know you have an answer for that, and I'd like for you to convey your response and also give us an update on what the prospects are that we would get a waiver to implement our Medicaid reform.
Well, a very good question and important one. We had a great victory a couple of weeks ago when Chairman John Dingell, who chairs the Energy and Commerce Committee, had some very kind and favorable things to say about the waiver. And I think that gives us a great deal of momentum. It's something that the people at the Office of Management and Budget who are now studying Oregon's proposal, I know are going to pay a great deal of attention to, and I'm very pleased that we had that breakthrough. There is considerable debate over this issue of how this is going to affect poor people in general. But I think it's important to burn off a little bit of the confusing fog on this issue so people get some specific facts. If we get this waiver in the state of Oregon, something like 65,000 poor women and kids would immediately get access to a decent package of Medicaid benefits. That's just immediately. Over the 4 or 5 year period, several hundred thousand would be covered in the private sector because companies would be required by 1995 to match the Medicaid program that was offered to low-income citizens. So over a 5-year period, there would be brought under the tent of basic coverage something over 200,000 individuals. Now, there has been a great deal of discussion in Washington about whether this in some way takes money from the poor and gives it to other poor people. You have probably seen this on various network television shows. That is not the case. In the first year alone, the Oregon legislature appropriated more than $30 million of additional money. That's on top of what is already being spent to cover the additionally eligible people. Governor Barbara Roberts came to Washington several weeks ago, testified before the committee I sat on, chaired by Mr. Waxman, did an excellent job of making clear that at any point, if there was not adequate funding for a decent benefit package for the poor, that she would put the brakes on the waiver right at that point. So I think that we stand in a very strong position. You're going to hear a great deal of fireworks about this. Senator Gore, who's a very good friend of mine, opposes this very strenuously and talked about how people were going to be losing benefits. And after pointing out that 65,000 of them would be added to the rolls immediately, I finally said, Al, you can't ration benefits from people who aren't getting any at all. And he went on to other subjects. So that's where we stand.
Our next question is from Ramona Johnson, member of the Human Services Standing Committee.
I'll have to say that it looks like you've covered every point of my question except one, so I'll maybe ask one that a friend authored here. It appears that Congress, according to what you say, is addressing issues that are peculiar to women, but what about those where the 15,000 men were treated? Are they addressing that so that federally funded medical research that applies to both men and women will be more equally administered?
Well, I personally feel additional funds are needed for health research overall, particularly as it relates to what's called outcomes research. It is really very interesting in this country that we generally test almost everything to try to determine whether it works. If you're running a steel plant or some other factory, you go out and test a particular approach to see if it works. We don't do that much in healthcare. And in the last year, there has been finally an interest in what's called outcomes research to try to determine what particular treatment works and under what circumstances, so that if we get that information, we can begin to incorporate it into healthcare. So I think overall we need additional funding in health research that would affect men and women. But I must tell you, when you look at the specific information about who is being included in research trials, it is striking that there is a preponderance, a dramatic skewing of the eligible population for these trials in favor of men, and that's why I mentioned that one particular study in cardiovascular disease didn't have any women at all.
And then we're prescribed according to how the men reacted, right? Here's my friend's question I'd like to read for you. Oregon is ranked high among all the states in HMO and PPO penetration. What is the attitude among members of Congress from other states towards HMOs, PPOs, and other forms of managed care, particularly as it relates to the role of managed care in health care reform?
Managed care certainly has many features that we ought to look to as we try to build a new health system, particularly the idea of trying to have incentives up front with the arrangement they have for paying in advance that provides an incentive for prevention, for outpatient services, is a very important model. Now, that is not to say that every health maintenance organization is a good one, because there have been scandals in health maintenance organizations, just as there have been in healthcare generally. And in fact, one of the areas that I have insisted on and that came up at our hearing on the Oregon waiver plan recently, a couple of weeks ago, is that because the Oregon waiver plan will make such extensive use of health maintenance organizations, we are going to have even more vigorous oversight and monitoring of those health maintenance organizations because they will play such an active role. If you want to abuse the system with a health maintenance organization, just as if you want to abuse almost anything, you can do it. And in the health maintenance organization, you can just say, well, let's just not give any care at all. They've already paid their money, and we'll just short them on care down the road.
I find it hard to believe that we aren't all willing to have at a congressman while he's here. Oh, yes, okay, here we are. A couple more questions. We have about 5 minutes remaining.
They're showing mercy.
Congressman Chuck Williams, member. I would like to restate Bob Shoemaker's question. With the criticism you heard today of Medicare in the report that we adopted today, could that possibly have any negative impact on the progress of the Oregon plan?
Well, I think Bob was absolutely right in saying that the numbers that the City Club has found, these aggregate numbers which show much more spending proportionally on whites than on non-whites, are probably representative of the Medicaid program as a whole. I have not had a chance to read the report. I spent a great part of my waking hours yesterday circling over the Chicago airport and doing all kinds of other wonderful things that you do to try to get home. And I have not read the report. But my sense is the findings of the City Club for Oregon are representative of the country. I think we do need to follow up on a number of these potential explanations. One that was given was this question of possibly many more non-whites securing health care services in the home rather than in institutional care. But let me say, just having listened to your debate, I find your report an important one, a troubling one, one that cries out for an explanation. And because there are federal funds involved and the well-being of our neediest citizens, I'm going to insist on a better explanation than has been given to this point, and I'll provide that to the City Club as well.
Congressman, thank you for coming, and as a woman, I appreciate your efforts on the behalf of women's health. I have a more general question, though, and that is on what is your feeling on national health care or on some way to get health care to people who are not under our health care system presently and don't fall under the low-income health care systems?
I think we have to have a national health system. We now stand with South Africa as perhaps the only Western industrialized nation that doesn't have a national health system. There are too many inequities and too many inefficiencies built into this labyrinth that we have created, a mix of public and private services, wherein each year we spend more money and yet more people fall between the cracks. Now, I am not one who thinks that under a national health system, the federal government should just take it all over and send you a little card with your name on it and indicate that you've got to call some 800 number to get permission to get a flu shot. I don't think that would be the way you would design a national health system. I think what we ought to try to do is make some judgments in this country, not unlike what we have done in Oregon with our Medicaid program, which eventually will cover the private sector as well. We've got to make some judgments in this country about what our priorities ought to be in health care. And that is the first step to building a national health plan. And the reason you have to make some judgments about priorities is that there are two inexorable forces driving health care that you have to build around. One is we have this technological explosion that each year moves us a little bit closer towards immortality. We're not there yet, but we are pressing the envelope, folks, and it is incredible. CNN can have a hearing on some health technology at noon, And by 5 o'clock in the afternoon, people will be calling up the office and saying, does Medicare pay for this? Does Medicaid pay for this? Where do we go to get it? So technology is pushing the system, and of course, our aging population. We will have many more older people, and they must be cared for in a sensitive and compassionate way. And as a result of those two forces, we could spend our whole gross national product on health care in this country and still not cover everybody unless we made some judgments about priorities. So I very much favor the development of a national health system, and I'm working on one myself as well. And I think to jumpstart the process, you've got to make some decisions about your priorities, and then you have to turn the system on its head and start focusing on prevention rather than what we do today, which is to build it around acute care and institutional services. I'm always struck, people ask me to come and talk about health care, and I say I'm glad to do it, but why don't we talk about sick care? Because that's what we have in this country. We wait until somebody's sick, and then we care for them in that acute care setting. I think I went on longer.
We're out of time.
Your question. Well, listen, you're very kind to have me, and thank you for the opportunity.
We are adjourned.